Thank you so much. Have a seat on the couch, please.
I feel like I'm at the View.
Yes, you are. This is the View. We're going to pretend. We just need our coffee mugs, right? All right. So we're going to go ahead and get started with the breast cancer case. I am so glad to be joined by my colleagues. I have directly to my left Reshma Mahtani from Miami Cancer Institute. Thank you so much for joining us. We're so sorry about the weather in Kansas, but we're grateful that you were willing to give us a try.
I was supposed to bring the sunshine. I'm from Florida.
I know. And Dr. Patty Tenofsky from Ascension Kansas, who is a breast surgeon in Wichita, and we're so grateful to have you. So we're going to jump right in. First, let me just say that there is so much to cover about breast cancer treatment this year. This past year has really been an incredibly exciting year. Tons of new drugs approved and new indications. So we cannot possibly take a very deep dive into that data today. So we picked out just one case which we think highlights probably the most important change in treatment. And then we're going to follow it up with just a couple of data points for you. But we just want to let you know we're limited by this 30-minute time frame today, so we're going to try to keep it very, very high level. So our first, the patient we're going to discuss today is a 34-year-old premenopausal patient that presents with a 3.8 centimeter left breast mass. She has a diagnostic mammogram and sonogram that confirm the presence of a mass in addition to two suspicious axillary lymph nodes. She has a biopsy of the breast and one of the axillary nodes, which show an invasive ductal carcinoma, which is grade 3. This is triple negative, ER and PR0 and HER2 by immunohistochemistry. So clinical stage T2 and 1, so stage 2. Triple negative breast cancer. And of course, this is a 34-year-old with triple negative breast cancer, so absolutely want to do genetic testing. I appreciate Katie and Lauren and Ani for emphasizing the importance of genetic testing. So critically important. Now, based on the NCCN guidelines, all patients with triple negative breast cancer should have genetic testing. So obviously this 34-year-old, very, very important, and that was negative. Here you see an image of an axillary ultrasound with a single morphologically abnormal level 1 node. A core needle biopsy is obtained, and this shows metastatic ductal carcinoma. And importantly, a clip is placed. And Dr. Tenofsky is going to comment for us later on the importance of that. And so what we are going to do is talk a bit about how we would approach, how we would approach a patient that presents with stage 2 triple negative breast cancer. And as I mentioned earlier this morning when we were talking about the HER2 positive early case, we know that pathologic complete response, that is achieving a complete response to the neoadjuvant treatment, is incredibly important. And there's really no greater example of this in breast cancer than in our patients that have triple negative breast cancer. So here in this graph, you can see the impact of pathologic complete response on outcome. So in the neoadjuvant chemotherapy setting, this has become the standard of care because we see that the patients that achieve a pathologic complete response have far superior outcomes to those patients that do not have a complete pathologic response. So understanding that response helps us tailor the treatment in the adjuvant setting. It can help inform their adjuvant therapy recommendations. We know that pathologic complete response occurs in about 30% of patients with triple negative breast cancer. For those patients that don't have a pathologic complete response, the risk of recurrence is incredibly high. And that is a tremendous area of unmet need and a great area of research as we try to understand what additional treatments we can offer for those particular patients. We know that once patients recur with triple negative breast cancer, the prognosis is extremely poor. On average, overall survival is about 18 months. So a better understanding of what is actually driving triple negative breast cancer and the development of targeted therapies is very badly needed. So at this point, I'm going to hand it over to Dr. Mahtani, who's going to highlight for us one of the most important studies of the year, really practice-changing for us, Keynote 522.
Thank you. So as Dr. O'Day mentioned, there's been so much exciting news over the last year in breast cancer, and we chose to highlight these data because it did lead to the approval of pembrolizumab in the early stage setting in July of 2021 based on this really important trial, the Keynote 522 study. And just as a reminder, this study looked at patients that had stage 2 or 3 triple negative breast cancer with a good performance status. Tissue sample for PD-L1 was done. I'll highlight as we go through the data that the efficacy that we saw in this important study was actually independent of PD-L1 status, which is quite a bit different than what we're seeing in the metastatic setting. So a large number of patients, over 1,000, were randomized 2-to-1 to chemotherapy, which included a platinum, carboplatin, either every 3 weeks or weekly, and paclitaxel, followed by anthracycline-based chemo. And that regimen was given in combination with pembrolizumab, or the other arm was with placebo and the same chemotherapy backbone. And then after surgery, regardless of whether patients achieved a PCR or not, there was not a second randomization. The patients that received pembro up front were continuing pembro in the adjuvant setting for 9 cycles, about 27 weeks. That's 6 months of therapy. I'll just make a few comments about the chemotherapy backbone because there's been a fair bit of discussion about this. So first, the incorporation of platinum. I think the investigators were really mindful of the fact that they wanted to make sure that we had our best chemotherapy regimens all delivered preoperatively so that there wasn't the criticism that, oh, well, maybe these patients didn't get optimal chemo. There had been a fair bit of discussion about the benefit of platinum in the neoadjuvant setting, and it wasn't really being routinely incorporated. We had several studies that showed it increased the pathologic complete response rate. More recently, there was an important trial called the Brightness study, which looked at long-term outcomes, event-free survival in patients that had had neoadjuvant platinum, and it showed an improvement in event-free survival. So I think, again, the investigators were really mindful of the fact that we wanted to make sure that that chemotherapy backbone were our best drugs. Another comment about the Q3-week anthracycline as opposed to dose-dense, because there's always the understanding that dose-dense therapy is important in triple-negative disease. I think that decision was made more based on just a pragmatic approach of these patients have gone through weekly platinum and taxane, and they're a bit beat up at that time point. So to be able to go on to Q2-week AC would be a bit problematic. And then, of course, just the practical standpoint of syncing it up with the pembro dosing given Q3 weeks.
So from a practical perspective, is that something, because this is something we were discussing amongst our breast med-onc group very recently, are you following strictly what was done here, or have you adapted the schedule? I know some of my colleagues are still doing the dose dense, but having the patients come in additionally for the Q3-week pembrolizumab. Are you using growth factor in the every 3-week dosing schedule? How are you approaching that?
Yeah, so my approach is you can't argue with success. You know, the trial did every 3-week dosing, and that's the way it was done in the study. And the important outcomes that we'll see in the next few slides were demonstrated with that dosing. So I'm following the Q3-week dosing, and I really do think that weekly treatment up front is really difficult for patients by the time they get through that 12 weeks of therapy. Many of them have had dose delays, have required growth factor support, and even though typically I don't usually do a growth factor with Q3-week dosing of AC, by the time they get to that point, a lot of them need it because their bone marrow is kind of beat up.
I think that's been the experience we've seen in our group, and we're starting to incorporate that.
It's a tough regimen. It's really a tough regimen. So let me see. Okay, the primary endpoint, as I mentioned, there were 2 co-primary endpoints of PathCR and event-free survival assessed by investigator in the intent to treat population. And then there were several secondary endpoints as shown here, and exploratory analyses were done as well. Just in terms of the patients that went on this protocol, you'll see that the median age, and this is what we would expect in a patient population with triple-negative disease, we tend to see a lot younger patients, about 48, 49. Performance status was 1 in about 12% of patients there. PD-L1 positivity 80%, but again, the results that we'll go through were really important in that there was no differential benefit based on PD-L1 status. And then weekly carboplatin was given in the majority of patients, and in my practice, that's what I'm following as well. And then about 50-50, almost even split in terms of nodal involvement. So we had seen data originally that showed an improvement in pathologic complete response, and here the delta was 13.6% difference in pathologic complete response. And I think we had gone through the importance of that as a prognostic endpoint. So understanding that the incorporation of immunotherapy was able to increase the path CR is certainly clinically meaningful, because we know the impact that that has going forward.
Comment for us, if you will, about the delta here of 13.6. I mean, we think about in triple-negative breast cancer, to be able to see something move the needle that much. I mean, to me, this speaks loudly as to the impact of the immunotherapy. What are your thoughts about that?
Yeah, I would agree. And, you know, I think in an earlier slide, we had said that about 30% achieved PCR. I think more modern studies would show that that number is a bit higher, more into the 40s or 50% range, as we saw in the control arm here. But that jump of 15 points almost in the path CR, I think that that is really, really an important endpoint. And we tend to think of a lot of the progress that we've made in breast cancer as incremental gains, but when you see such a dramatic result like this, I think that that seems more like a leap, and that's great news for our patients.
It is.
So then the long-term outcomes that we were really interested in seeing is primary event-free analysis. And so here we saw about an 8% difference, again, favoring the pembrolizumab. And this was, again, something that as we're looking at path CR as our early time point, what we really want to know is that translating into improved longer-term outcomes? And that's what we were able to demonstrate in this analysis. As we look at the subgroup analyses and look at the patients that benefited, you may think that it might just be the patients that have node-positive disease that would garner the benefit. But here in the subgroup analysis, you see that the benefit for the event-free survival benefit was seen regardless of nodal status, even stage 2 tumors. So I think this comes up a lot in clinic, because you see the patient with the larger tumor that's node negative, and you wonder, does that woman really need all of this treatment? Well, according to this analysis, it would suggest that yes, she does.
A really larger tumor is over 2 centimeters. I mean, it's not even a huge tumor. It could be a 2.8, 2.9 centimeter tumor.
Correct.
Node negative, those patients clearly benefited here in terms of event-free survival.
And then, again, this is extremely clinically meaningful, because what we want to see is a difference in distant progression or distant recurrence-free survival as our patients, when they do develop metastatic disease, as Dr. O'Day mentioned earlier, the prognosis is pretty poor. Although we've made some great strides in metastatic TNBC of late as well, certainly it represents the subgroup of breast cancer where we have the most work that we still need to do. So being able to spare our patients distant recurrences is, of course, the end goal here. I'll just mention a word or two about immune-related side effects, and then Anne, I'd love to hear about your experience. One thing that I think we're very fortunate in breast cancer is that we have benefited from the experience of our colleagues that treat other tumor types where immunotherapy has been used much more frequently. Of late, we've started using immunotherapy in the metastatic, and now based on these data, the adjuvant and neoadjuvant setting. And so it's been a bit of a learning curve. Some of these side effects can be very insidious, very difficult to pick up. So they really need to be on your radar and on the radar of the patients, and there's a fair bit of education that needs to occur. What's your experience been?
Absolutely, and I find myself, I'm so grateful for my fellows in my clinic who've had a great deal of experience in the GU and the lung space that has, utilized a great deal of IO. But just kind of this slide we wanted to include because we have a great number of primary care colleagues here today in the room and joining us virtually, and just to think about, these patients might not, especially when they're in their adjuvant portion of their pembrolizumab, right? They might be 4 or 5 months out from their breast cancer treatment, still getting this every 3-week pembrolizumab, and they present with shortness of breath and a cough, they might go to the family medicine doctor. They might not necessarily call us. So it's very important for us to be aware of the broad sort of range of toxicity that we can see with checkpoint inhibitors. So just to divide by body system here, you see the endocrine. We definitely see a great deal of thyroid dysfunction. I think that's the thing I've probably seen the most commonly. And so that's something we have to screen for regularly. If we're not looking for it, we won't find it until the patients are often highly symptomatic. Respiratory, of course, the pneumonitis is something we have to watch out for, and it really requires early institution of treatment. The hepatitis, that is something I recently experienced, unfortunately, with a neoadjuvant patient with an IO-induced hepatitis. I was so grateful for our hepatology colleagues in the hospital to help us manage that. But again, these are things we really have to astutely be looking for. Nephritis, the patients obviously can deal with that. Unfortunately, I had a recent case of that for a very young patient with absolutely no predisposing factors for renal dysfunction that developed an acute nephritis after only the 2nd dose of adjuvant pembrolizumab. So that's the other thing I think in my experience, and I would be curious to hear your thoughts about this as well. This doesn't seem to necessarily be a cumulative toxicity.
Correct.
Something that can happen at any point in the treatment, and so.
There can be late presentations, and that's something, again, that we're not used to seeing with other sorts of therapy that we're dealing with. And another pearl that I would just mention is that in patients that do develop thyroid issues, it's really important to also make sure that that patient doesn't have concomitant adrenal insufficiency because that can be linked. The other thing is for these patients that are getting neoadjuvant chemo and IO and then are going to surgery, it's really important to check a cortisol because obviously you don't want to miss adrenal insufficiency in a patient that's about to go to the OR.
Absolutely, thank you for that. Neurologic, I know my colleague Lauren has had a difficult, challenging case with a patient that developed significant encephalitis from IO treatment. We see in terms of the eye, conjunctivitis, blepharitis, retinitis, all different kinds of inflammatory eye conditions. Cardiovascular, we're seeing that less commonly, myocarditis, pericarditis, and vasculitis, something though that we do have to be aware that can happen. And then of course the GI issue, that is I think the thing that probably tends to be the most obvious. The patients are calling in with diarrhea, which the tricky part is that when they're getting their chemotherapy concomitantly with the IO, it's always tricky, at least I found it difficult to know how much of that is caused from the chemotherapy and how much of it is caused from the IO. Obviously treated differently, the chemotherapy-induced diarrhea we would treat with anti-diarrheal agents, and the colitis would need to be treated with high doses of steroids. So sometimes that can be difficult for us to sort out.
And engaging with our colleagues in other tumor types.
Mm-hmm. So this particular patient, we would start as a young patient with stage 2 triple-negative breast cancer. We would start her based on the newly approved and data that we just showed you from Keynote 522. She would start neoadjuvant chemotherapy. And so in my practice, I've been starting people on exactly the regimen used in the trial with the dose and schedule used in the trial, as you have been doing as well. Following chemotherapy, she has an excellent clinical response. So her mass is no longer palpable, it's no longer apparent radiographically, and end of treatment sonogram demonstrates a complete imaging response in both the breast and the axilla. And so importantly, she had a placement of that clip in that positive axillary node, but complete imaging response in the breast and axilla. Okay, click forward. So Dr. Tenofsky, we just want to ask you to comment. At this point, now you're faced with operating on this patient that has no clinically apparent cancer, and how do you approach that? What are your thoughts as you work through that?
So, well, obviously it makes it easier for me, so I appreciate my colleagues. Historically, neoadjuvant chemotherapy was used different. We would have very large cancers, inflammatory breast cancers, which still happen, locally advanced breast cancers, and we would actually need our colleagues to help us shrink the tumor so we could even do a mastectomy. Over time, we were able to convert the mastectomies to breast conservation, and neoadjuvant helped us have better cosmetic results. Now we've actually started converting node-positive patients to node-negative patients, which can allow us to omit axillary node dissection and decrease our resultant morbidity, which is mostly lymphedema, which I'll talk about in a second. We see response rates of up to 90%, even before the newer regimens that they were talking about. We saw good response rates. You hardly ever saw someone progress, less than 5% of the time. So sometimes just shrinking 50% would help us be able to conserve the breast. Overall, pathologic complete response is about 20 to 30%, as we talked about, and of course it's much higher with HER2 positive tumors, and higher with triple negative. It's lowest in our ER positive tumors. In this particular patient, I would have a conversation with her, and I would have actually spoken to her before we started treatment. She would have had an MRI to make sure there was no other disease, and we would have had her completely worked up before she started neoadjuvant chemotherapy. And then we would discuss lumpectomy versus mastectomy in this situation. The tumor was fairly large to begin with. It has shrunk. It's gone. The only way we know it's there is the clip that was placed in at her biopsy. So she is certainly a candidate for a lumpectomy now. It's important to note that, especially in triple-negative breast cancer, there's absolutely no difference in survival between breast conservation, and there's no difference in local recurrence with breast conservation. This is always a surprise to my patients. Sometimes I feel like they fall off their chair when I say that, and they doubt me sometimes. But the research is very clear that with triple-negative breast cancer, there is no difference in local recurrence even. And there's even some research studies that show that there might be a little bit of a benefit to breast conservation with triple negative, and that's all about radiation. The surgeons can't take credit for that. Triple negative cancer, definitely, as we talked about, is associated with BRCA, so I would for sure make sure she has had BRCA testing, because most women with BRCA at this young age would choose preventative mastectomies if she had the BRCA gene, but this particular patient does not. So ultimately, it's the patient's choice after a good informed discussion and education is given to her. If she is leaning toward a mastectomy, we have to discuss the possibility of radiation. It's never for sure or a not for sure with triple-negative breast cancer after neoadjuvant. We don't have the research trials to tell us what the right answer is here, so I have to explain to her she may get radiation and that could affect reconstruction. So we have to discuss the pluses and minuses of reconstruction if she has to have radiation or not, and the risk involved with that. Now, coming to the lymph node, this is the most exciting part about better responses with chemotherapy, because salvaging lymph nodes can really improve the quality of life for these women. We now do something called a targeted axillary node dissection in patients exactly like this particular patient. The patient will have a clip placed at the time of her diagnosis into the known positive node and into the cancer in her breast. At the time of surgery, instead of doing an axillary node dissection, which is what we did for years and years, she had a positive node, so we would do a node dissection. And that happened until just a few years ago, when some trials said this particular technique is safe. What I would do at surgery is I would remove that lymph node that has the clip in it, because I knew it was positive to begin with. And I have to confirm that I've removed it. So I have to do an x-ray proving the clip is out. So I took out the correct lymph node that used to be positive. And then we use radioactive sulfur colloid to help find the first lymph node in the chain of lymph nodes, and a blue dye as well. And I would hope to take out at least one more node or two more nodes. And all of those nodes will be sent to the pathologist while the patient is still in the operating room. And if they are all negative, then I can stop, and I don't have to do an axillary node dissection. If the sentinel node is positive, then we would continue to do the axillary node dissection. From a technical standpoint, from a surgeon standpoint, sometimes finding the clip node is hard, because chemo not only makes the lymph nodes turn negative, it also shrinks the nodes like crazy. So these lymph nodes after chemotherapy are tiny, tiny, 1 or 2 millimeters sometimes. You can't hardly see them. So sometimes it's very difficult to find that lymph node after chemotherapy. It's not easy like in this picture where you see the lymph node, the clip in there.
And Dr. Tenofsky, a question came in. Can you just comment about how clip migration impacts the surgical approach, so both in the primary tumor and in the axilla? How often do you encounter that, and how do you approach that?
I encountered it quite a bit. So the most important thing is if the clip has migrated, we need to make note of that. So after the 4 months or 6 months or however long the patient has chemotherapy, that we know where the actual tumor is and not where the clip is. They can be several centimeters apart. So sometimes that would require putting a different clip in even before they start chemo. We absolutely confirm that the clip is in the correct position before they would start chemotherapy, both in the lymph node and in the breast, and that may require placing another clip. Finding the clip in the breast is easy because you can do a mammogram and you can put a wire in like we've done for years and years and years. But finding the lymph node clip can be hard because sometimes the lymph node is too high for the mammogram to reach. So how do you find it? Sometimes you can see it on ultrasound. If you can't find it, you have to do an axillary node dissection. So we have come up with techniques, new technology, fantastic technology, where you can put a clip in the lymph node that has either radar in it, or radio frequency, or magnetic, and then you have a device like in the picture where I can put it on the armpit even months and months later, and it will beep and tell me where it's at. And that technology is not available in my town. I'm trying. I think you all have it, but my town of Wichita does not have it. So that technology is the most important piece of technology for this particular procedure. And it could save a woman from having to have all her nodes removed. So I think it's important, even though it's pricey. So let's say the node converts to negative. We don't do an axillary node dissection. If she's having a lumpectomy, it's easy. She has to have radiation. That's the standard of care for a lumpectomy. Now, doing extended fields or tangents is controversial. And that's when you radiate up around the collarbone and do extended fields. That's controversial. With a mastectomy, most say no to radiation if the patient has a complete pathologic response, nothing in the breast, nothing in the lymph nodes. But still it's controversial. I have radiation oncologists who want to would radiate this patient no matter whether she had
I would say at our institution what we would do is those patients would all have a consultation with a breast radiation oncologist and have a careful, thoughtful discussion about the risks and benefits and then shared decision making. But yes, it's a very controversial.
We do not have the answer, but this trial, NSA-BP B51, should give us the answer. It will help answer both controversies here because patients from both groups were placed into this trial. It will help know if we need extended fields with lumpectomy, and it will help us know if mastectomy patients need radiation if they had a complete pathologic response. The trial is accrued and we're awaiting results. So this is going to help us so much for our reconstruction patients to know whether they need radiation or not. Now, if the sentinel node is positive, or if I can't find the clip, or I can't find any sentinel nodes, why would that happen? It sometimes happens if the patient started with inflammatory breast cancer because the lymphatic channels are full of cancer and they are occluded and it just doesn't work. If you cannot find a sentinel node or the clip node, you have to do an axillary node dissection. Or if the sentinel node is still positive, you have to do an axillary node dissection. That is the current standard of care in 2022. But this trial, this Alliance trial, this is an amazing trial. I put patients into this trial and we are now awaiting results. This trial, if the sentinel node was positive, I would call, they would randomize my patient to either get a node dissection or not. And if they were randomized to not get a node dissection, I would have to stop. And it was felt kind of strange because that's against what I've been doing for years and years and years. So I had patients in both sides of the trial. If it shows that radiation is as good as doing an axillary node dissection, we won't be doing axillary node dissections anymore, and that will be practice changing.
Hopefully that'll be something we'll be talking about next year. Yeah.
It doesn't know. It seems like when there's no difference in the two groups, the trials take longer, which is a good thing. So for me, neoadjuvant chemotherapy has significant benefits. It can allow breast preservation when the tumor is initially too large for this, which in the first picture, I just showed a mammogram and an ultrasound showing tumors shrinking. They didn't go away, but they shrank. And that's going to make me look better as a surgeon when I don't have to take as much tissue out. The breast is going to look better. In the second picture, the MRI there, you see the cancer went completely away. And there was nothing left. All I would do is take a little tissue around the clip to make sure there's no cancer there, and the patient would have an excellent cosmetic result. But also what's new is that we can allow a positive node to convert to negative, utilizing a targeted axillary node dissection, preserving lymph nodes, and decreasing our most dreaded complication, which is lymphedema, which is shown in that picture. I think is that right?
Yeah, perfect. Thank you so much for that. So one of the things we just want to summarize, and this is so critically important because as we saw in our patient that had a complete pathologic response, it's important for us to look at the results from Keynote 522. And what we see is that if you look at the top two curves, that is the group of patients that all had a complete pathologic response, looking at the difference between those that received adjuvant pembrolizumab and those that received placebo. So you can see that even in the group of patients that had a complete pathologic response, there is a numerical difference of about 2% for receiving the adjuvant pembrolizumab. So again, this is something that I've seen when we're doing second opinions and other things. I don't know if you've run into this, where patients are sometimes being told that because they had a pathologic complete response, they don't need the adjuvant pembrolizumab. But in fact, there is a numerical difference here, and we don't have a way to predict. Maybe not all of the patients that get a path CR will end up needing adjuvant pembrolizumab, but right now we have no way to predict the patients that will benefit and those that will not, so this is critically important. And then of course the patients that do not have a pathologic complete response, you can see the impact there on recurrence. Their recurrence rates are much higher, and the greater impact of pembrolizumab, obviously, because they have a higher risk of recurrence. So important for us to remind ourselves that. So just a couple of conclusions for us in the phase 3 Keynote 522, neoadjuvant pembrolizumab and chemotherapy followed by adjuvant pembrolizumab results in a highly statistically significant and clinically meaningful improvement in event-free survival. The pre-specified event-free survival sensitivity analysis showed a robust treatment benefit of neoadjuvant pembro plus chemo, followed by adjuvant pembro for previously untreated non-metastatic triple-negative breast cancer patients. The benefit was generally consistent across a broad selection of pre-specified subgroups, including those defined by nodal status and overall disease stage. The safety was consistent with what we know about pembrolizumab. These results further support pembrolizumab plus platinum-containing neoadjuvant chemo, followed by adjuvant pembro after surgery as a new standard of care regimen for patients with high-risk, early-stage triple-negative breast cancer. So this is absolutely one of those practice-changing things that happen sort of the Monday morning, change of standard of care for all of us. Quickly, because we're out of time, but I couldn't let this pass. Again, as I mentioned, this has been an incredibly busy year for us in breast cancer, early stage disease, and we don't have time to talk about a case in regards to the Monarch-E study, but I did want to talk about our hormone-positive, HER2-negative patients, so those that have node-positive, high-risk early breast cancer. So you can see here the different cohorts from Monarch-E and Cohort 1, 4 or more axillary lymph nodes, or patients can have lesser nodal involvement, but have at least one adverse risk factor, including grade 3 or a tumor size over 5 centimeters. And in Cohort 2, those patients, a similar sort of stratification, but based on Ki-67 as well. So these are high-risk, hormone-positive, HER2-negative. This was over 5,500 patients that were randomized in a 1-to-1 fashion to receive adjuvant abemaciclib, of course a CDK4/6 inhibitor, at the dose of 150 milligrams twice daily for up to 2 years, plus standard of care endocrine therapy for 5 to 10 years as whatever is clinically indicated, or standard of care endocrine therapy. So basically the standard anti-estrogen therapy or the standard anti-estrogen therapy plus abemaciclib, a CDK4/6 inhibitor, the primary objective, invasive disease-free survival. And what you can see here, of course, for the group of patients that received abemaciclib plus endocrine therapy, with invasive disease-free survival at 92.2% compared to 88.7%. And you see there on your right, the distant relapse-free survival, 93.6 compared to 90.3. So this, of course, led to the approval of adjuvant abemaciclib for us. And just to look at the impact of Ki-67, this is something that we now have incorporated as standard for all of our pathologic specimens at our institution, and I'm sure you're doing that now as well, because Ki-67 was an important predictor in this particular study for response. So the FDA approval for adjuvant abemaciclib plus endocrine therapy for those selected high-risk hormone-positive early breast cancer patients in combination with endocrine therapy. And the FDA indication is here. It's very specific, and we were all a little bit perplexed and surprised that they put this very specific Ki-67 of over 20%. However, the ASCO guidelines were quickly updated because many of us felt that the approval really should have reflected what was done in the clinical trial, right? Which is what the ASCO guidelines specify. So effectively, we're recommending adjuvant abemaciclib for any patient that would have been eligible for the trial. So that includes patients that have higher lymph node involvement or have larger tumor size, grade 3, high Ki-67. You can see the ASCO guidelines here. Those are widely available for anyone to just pull up on Google. And so I would encourage you, when you're seeing all of your patients back in clinic that are now finishing their surgery, finishing their radiation, you're having the endocrine therapy discussion, we now have to have an additional discussion. Is this patient eligible for adjuvant CDK4/6 abemaciclib? So something that's incredibly important for us. So again, we talked about the summary from Keynote 522. Dr. Tenofsky shared with us some important information about limited axillary dissection. I'm so glad to know more about that. And then the Monarch E trial, which led to the approval of adjuvant abemaciclib in addition to endocrine therapy for our hormone-positive, high-risk early-stage breast cancer patients. So that was a super whirlwind. There's so much more that we want to be able to discuss, but time constraints today don't allow us to do that. So I want to thank you all. Thank you guys for coming from Wichita and from Miami. We're so grateful. All right.